Hello, I'm Norman Swan. Welcome to this Rural Health Education Foundation programme, which is a special interview on maldistribution around the community in terms of the health workforce. And to talk about it is Professor Des Gorman, who's Dean of Medicine at the University of Auckland, has worked in Australia, knows Australia well, has particular interest in Maori health, being a Maori physician himself. And we're talking about the gap, Des. Welcome to the programme.
Thank you, Norman.
So you're doing a bit better with the gap in New Zealand than we are.
Yes, well, everything's relative, of course. I'm reminded of that old aphorism about in the land of the blind, the one-eyed man is king. So perhaps we are one-eyed Indigenous health deliverers in the land of the blind. We're doing better, but having said that, we're hardly meeting the challenge.
So it's about 9 years of a difference.
Yes, it is, which between Indigenous New Zealanders and Pākehā New Zealanders, that's right, which is a greater gap than between whites and American Indigenous peoples. So we don't take that as a particularly outstanding achievement.
Now, why do you think that is? Because the reason you think that is, and it should be said that you're Maori yourself.
Yes.
Why you think that is, because a lot of doctors, pharmacists, primary healthcare practitioners who are watching this, clinicians who are watching this, will say, well, look, it's all up to housing, finance, economics, employment. We've got very little role to play here. But from the perspective of a Maori physician, also a Maori health educator, what is the role for people watching us converse?
Yeah, I think you're right. By the way, they are right. Housing may have a greater bearing on referral to hospital than acuity of illness, but putting that aside, we have a maldistributed workforce in New Zealand, as you do in Australia. 15% of New Zealanders are Maori, about 2.5% of the health workforce is Maori. New Zealand has 2 out of every 3 rural doctors are trained overseas. There's a major cultural disconnect between the communities that these doctors serve and the communities that the doctors originate from. And I'll give you some examples for that. Very subtle differences in philosophies, understandings, concepts can end up with very major differences in health understandings. And some of the barriers to health access are actually quite subtle.
Can you give me a tangible example?
Yeah, I can. I'll give you an example from my own family, for example. One of my aunties died of lung cancer. Well, the first issue is Maoris smoke 2 to 3 times more than Pākehā New Zealanders. And of course, the Pākehā perspective in that regard is we need another white middle class health awareness campaign.
Don't smoke.
Exactly.
As
if Maori don't know they shouldn't smoke. Or, you know, don't eat McDonald's and run around the block. It beggars belief to think that Maori don't know. The question, of course, why...
And the same would go for Aboriginal people.
Absolutely. And you see, you can intelligently articulate, yes, it's a good idea to not eat McDonald's and run around the block, but on Saturday when there's a funeral, I go to the tangi. I'll know exactly how important the person is who's died by the nature of the food there. I can look around the room and I can say to you, Norman, that's the most important person here, by the nature of the food served to that particular person. And it's the deculturation of food and the sort of models of health and health perceptions that matter. I'll give you another example before I get back to Sally. I haven't forgotten Sally. We were offered a lot of money to look at skin cancer awareness in outdoor workers, and this money was offered to us by the Cancer Society. And their idea was that they'd have a slip, slop, slap campaign to encourage people to work outdoors to avoid non-melanoma skin cancer, which is a good idea, isn't it? And they asked me what I thought would be interested in the money. I said, no, it's a complete waste of time. Because the person you're trying to influence is going to go to the pub tonight, excuse my language, get pissed and drive home drunk. He'll go home with a woman he's never met before. They'll have sex all night without a condom. He'll drive to work the next day still hungover. He and his mates will smoke a couple of joints on the way to the forestry site, and then he'll climb a tree with a running chainsaw. Now,
what's a bit of sun?
Precisely. You imagine that in your white middle class intention way, you rush above the tree saying, please, please.
There's some factor 30 here. If you could just stop the chainsaw for a moment.
So, health at risk perceptions, we keep taking a white middle class view of what health risk perceptions are and what health risk behaviours are, and assume that if we articulate them in our idiom that these will be understandable to anybody else. So the first thing about Sally is that she smokes. Whatever the idiom is of the anti-smoking campaign, it's not a Maori idiom. The second thing is she doesn't present to anyone until she has very advanced disease. And I said to her, you silly old bugger, what are you doing up here in the far north getting this sick before you went and saw somebody? And she said, well, Desi, you know, she's teaching me now as I'm a 5-year-old. And I'm
You will always be a 5-year-old.
absolutely breathtakingly stupid, hence she's got to speak slowly to me. She said, how could I possibly go down to the nearest town, which is Kaitaia, and take my blouse off in front of those men? Because there were 2 doctors in Kaitaia, one was Indian and one was South African. And for her, the idea of visiting either an Indian or South African doctor and taking her blouse off was just a barrier too far. So in that case, we had 2 issues. One was the very nature of the anti-smoking campaign, which has had little traction among the Maori. The second thing is, to her, the barrier of going and seeing men from such a dissimilar culture to her meant that she just was not going to go into that situation.
But what can you do? So here's the practical outcome. So understand cultural sensitivity. Yep. The reality is you've done better than us in terms of training Maori doctors than we have so far in training Aboriginal Torres Strait Islander doctors and health professionals, but it's only a little bit better. There'll never be enough to go around. For the next 20 years, we are going to be dependent on international graduates at the very minimum in rural areas, and particularly in Aboriginal communities. So is it just a barrier too far and we just got to accept it? Or yes. Can an Indian trained doctor change his or her ways in a way that will help? I mean, clearly this is an issue which doesn't lend itself to a simple answer.
And very clearly the long-term solutions are to have the communities of doctors bearing a striking resemblance to the communities they serve. I mean, that's a no-brainer.
But it's also a huge task.
It is, and it's also a long-term task. And in our situation, I'm sure the same that I know is true in Australia, the problem isn't my willingness to train Maori doctors. The problem is my ability to recruit from secondary school. And the failings are occurring a long time before. And if I take Maori graduates, then I'm robbing Peter to pay Paul, because I'm taking probably the most important community in Maoridom is actually primary school teachers, not doctors. So the last thing I should be doing is actually depleting those reserves.
But what you're talking about there is the task of a generation.
It is. So let's come back to the immediate task. The first thing I think is that we need to incentivise the most culturally appropriate people to move into the communities where they're going to be best put to task. At the moment, I think we have a very significant economically driven malalignment of resource and need. We don't incentivise generalism, we don't incentivise rural generalism, we don't incentivise urban generalism. We may have a range of affirmation programs in place through medical schools, but at the end of the day, the drivers are to procedural or what I call partialist practice. New Zealand's far worse than Australia. We are essentially the most reliant country in the OECD on overseas trained doctors. And unfortunately, 2 out of every 3 rural doctors in New Zealand are overseas trained doctors. So we've actually maldistributed within that again. And there's the fundamental problem. And it may be as something as simple, for example, as...
But it's not necessarily guaranteed that a Pākehā doctor, trained in Auckland, yes, Wellington or Dunedin, is necessarily any better than somebody who comes from South Africa. And arguably, somebody who comes from South Africa might be better off because they've worked in black communities.
I'm not sure that's true. We have taken Indigenous health and made it an across-curriculum domain. See, in the old days we'd have a week of Maori health or a week, and what that did is it said, this is not really mainstream, this is something you do 1 week in your 6 years, it's almost showcasing. I'm now saying that in fact the Indigenous health domain has to be part of all the teaching we do at every level that we do it. And that understanding, the Maori word's kaupapa, which means concepts and philosophies. If you don't understand someone's concepts and philosophies, you'll have a lot of trouble interpreting their disease and their perception of that disease, particularly where it lends itself to preventive medicine. And if we are to make a big difference in Maori health, it'll be around the major threats of obesity, diabetes and heart disease, which are really in the preventive domain. And that's where you need to understand kaupapa intimately. And interestingly, if you're going to change behaviour which lends itself to diabetes, it probably is more to do with sociologists than anthropologists.
Well, I was going to say that. I mean, given the reality in Australia and in New Zealand that there's a shortage of doctors, there's a shortage of nurses and all other health professionals, and you're not necessarily getting indigenously trained doctors, whether they be black or white. Is it really the job of doctors here that we're talking about? Or
in part, it is Norman, but we have to understand the limit that medicine has in this regard. For example, we just had a major program looking at preventing diabetes, which was essentially, to put it crudely, run around the block, don't eat McDonald's, which it was as puerile as it sounds. Now that should have been led by sociologists and anthropologists, because the real issues were the cultural underpinnings of those behaviours. I've got no...
They wouldn't have designed it that way.
No, quite the opposite. It was designed by doctors and led by doctors. So there was a situation where we were trying a medical solution to what is not a medical problem. But coming back to that question you asked, when you have a shortage of doctors and a shortfall of doctors to meet Indigenous health needs, there has to be an incentivisation for the doctors trained who are contextually relevant to work in those practices. And it's the obligation, in my opinion, of Australian medical schools to do two things. One, to have an affirmation program they don't apologise for. And the second is to make...
Indigenous students.
Exactly. And the second is to make sure that every student who leaves there sees Indigenous health and health concepts of the Indigenous people as an integral part of everything they learn throughout that process. I think there are three domains in medical education. One of them is the bit that they were obsessed with in your day and mine. For those of us who were dinosaurs, it was around information. Now that's transferred now to information use and problem solving. But we've been fixated with that domain. The other two domains are professionalism and career choice. And too much in medical education we've been obsessed with the first bit, and not enough with what sort of models are we putting in place which address the second bits. The whole professionalism domain, which is around communication, and it's around ethics, and it's around morality, and that's where Indigenous health sits. And in career choice, how do we incentivise people to take up career choices which actually quite deliberately have Indigenous health as a major stream? And the first way to do that is to make sure that everyone teaching throughout a whole medical curriculum has Indigenous health as an obligation, not as something which you tick off on a box or have some special occasion to do.
And what about those people who are already graduated, they're out there working, whether or not they graduated in Dublin, Delhi, or Johannesburg? What about them, and whether they be pharmacists, nurses, or doctors?
Yes. Well, you know as well as I do that some people have intrinsic ability and sensitivity to pick up cultural themes and norm and become very, very good at understanding the differences between their perspectives and the perspectives of their patient populations. And that's more likely to occur when you have a reasonably intimate relationship between the practitioner and their communities. It's not going to occur where there's shift work or there's multiple practitioner practices. It's not going to occur where the people you're trying to address are marginalised and don't gain access to the practice. So,
just picking up on something, you say it's not going to occur where you've got multi-practitioner.
It's less likely to occur when there's a lack of intimacy. I mean, where it's most likely...
You mean multi-partner practices where you don't see the same patient all the time and they haven't organised things accordingly?
That's what I meant. To some extent, to understand Indigenous kaupapa by assimilation or by osmosis requires exposure. It also requires that the person being exposed, the doctor, has the ability to be sentient. Now that'll work for some graduates, it won't work for others. And there are real barriers for overseas trained doctors, particularly those whose first language is not English. And I'll give you an example. I saw a patient last week in a clinic that I ran, and I said to him, "Are you still having those funny turns?" And his response to me was, "Not really." Now, as an English speaker predominantly, I heard him say yes. If I'm a non-English speaker, I'd have heard him say no. So sometimes even very subtle differences in language can send you down paths. So I think the non-New Zealand trained doctor, the non-Australian trained doctor, first has to get the local language, secondly then has to understand the local concepts and philosophies. So I'm not saying it's impossible for an overseas trained doctor to provide a health service to Indigenous peoples. In fact, quite the opposite. What I'm saying is it's very difficult when in fact the only way you're learning is by trial and error.
So what structures are you putting up in New Zealand to help the existing workforce?
Yeah, good question. We have an affirmation program in place for Maori and Pacific students and also for underprivileged students.
No, I understand that. I'm talking now about the existing workforce that's out
there.
I
see what you mean. We are trying to build into continuing medical education as much as we can the sorts of discussion we're having now. And in fact, the response we get from most practitioners is very much the perspective you just presented, which is, well, listen, how do I do this? I'm here already. I'm basically doing okay. People find it quite offensive when you say, look, you're malaligned to your community. You don't understand the kaupapa of the people you're treating. For example, that young Maori boy who you told the family is schizophrenic, you'll never see them again because the family believes he's possessed by the spirits of his grandfather. And because you didn't articulate that, and because you didn't understand that, you'll never see them again. Now, you think that he's going to take that to major tranquilizer. Let me tell you what it's going to be. It's going to be in the rubbish bin on the way home because in fact you never once understood the perspective of that family. So when we do this, we've found that in an abstract sense, there's not a lot of traction, but when we inculcate Indigenous health into CME, the way to do it is by stories. And I wrote an editorial for IMJ, and I thought I can do this conceptually, or I can just do it by stories.
You told a story where you got thumped after a decision you made as a naval medical officer.
Yes, well in fact there was a mismatch between our perspective of mental health and Maori mental health.
Maori doctor, heal thyself is the moral of this story.
Well, I tell you what, I need to learn to duck better, because this old lady hit me with a stick and she didn't miss. The story was, I was in the New Zealand Navy. I was in the Australian Navy originally, but I was in the New Zealand Navy at the time. And this young Maori sailor had gone quite mad. He was taking his commands from the ship's plumbing, not from the ship's captain, which is a problem on any ship. The plumbing not being particularly good at giving sensible commands. Yeah. So the idea was we'd survey him in the Navy, and it proceeded along normal lines. And of course we called a meeting just to sort of let his family know, and one of the first things that overseas trained doctors really are taken aback because the whole family turns up. I mean, the whole family. Grandmothers, the whole lot. And they turned up.
So you could have 20 people in the room.
Oh, absolutely. And I articulated the Navy perspective.
Because you were discharging him under medical grounds.
Precisely right. And there was the classic case in point. The old grandmother knew that her grandchild, called a mokapuna, was possessed by the spirits of his grandfather. Now, I should have known better, because if I said at the beginning of this, I understand that this is a blessed boy, I understand that this is a special boy, I understand that this boy is one of the hopes for this whānau because his grandfather lives through him, but unfortunately, operationally, this is incompatible with what we want him to do. So we are unable to employ your special boy. Because I presented in a schizophrenic idiom, she hit me with a stick, and she didn't miss. So I'm actually not saying that in fact those of us who have been raised in Maori communities or trained in Maori idiom get it right, but at least I knew where it went wrong, and what I was able to do quickly.
And there's been interesting research in the Northern Territory which shows that even Aboriginal health workers can get it as wrong as non-Indigenous health workers because of mismatch in language. So what about the mid-level trained Indigenous health worker? You have them in New Zealand, the Maori health workers. We have Aboriginal health workers. You know, I'm going to sort of say the unsayable. Do they provide a useful role, or are we still being doctor dependent here?
That's a very good question again. One of the things I think we need to do, a conversation for a different day perhaps, is when we identify just what it is that doctors do, need to identify on the basis of that clear delineation of doctor roles is what other sorts of health providers we want and need. The idea of a community health worker, although we usually use some pejorative term like doctor boy or physician's assistant or barefoot doctor, those are profound.
Or nurse practitioner.
Absolutely. Well, nurse practitioner is a classic case of failed workforce substitution because of the politics of it. But coming back to the community health
not necessarily in Australia though.
No, in fact there's some good models in New Zealand too, but right now we should have a incredibly strong nurse practitioner community. The question I'm not asking, the question I put there to you is not does it work, but why hasn't it been on a much broader base, and why isn't it providing a whole range of procedural services to free doctors up to do the problem solving?
So you're suggesting that medical dominance has got in the way?
I'm suggesting that even the nursing councils got in the way by making it time punitive, and they also had the model was back to front. Instead of the doctor being at the front door solving the problem for nurse clinics, it was nurses at the front door. Even the model was back to front. But the community health worker, we have two views of that. One is that it can serve an immediate purpose and provide an articulation between a malaligned medical community and a community of need. The other thing is it acts as a bridging program for young Maori or young Australian Aboriginals who don't have strong interest generally in health services.
So it's like a transition to other more advanced professional work?
Well, to different professional work, that's quite right. And the sort of view that we have of it is a sort of a common year of health sciences which provides knowledge of human biology, human disease, epidemiology, public health, and then a year of modular training along specific lines. For example, you might train someone in drug and alcohol or sexual health, or you might train them in obesity and diabetes. And the beauty of this then is you can readapt and reconfigure the community or the health provider community as you need. As the change needs, you come back and do that module, and then so what that model lends itself to is it recognising the fact that health system planning will always be wrong.
Yes, but it also, it's an awful lot of work, and you've recognised this in your writing as well, that a doctor doesn't need to do.
Precisely.
And a doctor could actually become much more of a consultant, even at the general practice level, and allow other people to do tasks, even ones that are perhaps even highly remunerated at the moment, such as colonoscopy and cataract surgery.
Couldn't agree more. It's interesting to me that when you meet with deans of Australian medical schools, or deans of UK medical schools and elsewhere, that the debate around what a medical school is and what it should be doing seems to be a debate within that medical school, not with its community. And I think most medical schools have lost track of just what their social contract is. And the issue around the doctor of the future is this: how would any society, or why would any society, spend several $1 million to train someone who it takes 15 years to train to sclerose varicose veins? Does that make any sense? And if you take the Fred Hollows experience in cataract surgery, you'd take it even further and say, well, why would you spend $3 million and 16 years training someone to be an ophthalmologist to do cataract surgery? And then you begin to say, well, take the other way around, and you say, well, what does justify the training that we invest in being a doctor? And when you wander outside the cognitive realm, the answer is not much. And so if you were taking an economic perspective of the doctor of the future, a socioeconomic perspective, you'd probably argue that once you get beyond patient differentiation, care planning, care oversight, that it becomes very difficult to justify a lot of our current roles.
So why are you questioning the community health worker then? Because presumably, even now, before you define they are a solution to significant distribution problems.
I'm not challenging them all. I think they are exactly what we need. I actually am a strong advocate of community health workers. The reason why most of these models have failed is they haven't begun with an employment model. What would generally happen is that a group of well-intentioned people put together a health worker project, train people, and then try and find some sort of employment for them.
So in other words, you haven't defined the need before you start.
No. Where it does work is when some health employment authority says, we want people to do this, and then go to an educator and say, look, this is not a philosophic debate for you. We need people who can do the following things.
Teach blood or teach them to do this or that.
Please train someone for this purpose. So I think far from depreciating the roles of community health workers, I actually think the future lies in active workforce substitution. At the moment it's passive, your profession and my profession. At the moment of giving away the things that we feel don't reflect on us well for status, or the things which we don't make money out of, that's not the way to do this. What we should be doing is saying workforce substitution has to be active. What are the things that doctors need to be doing by virtue of their training and their knowledge?
Now, if a pharmacist or rural nurse is watching this, they're thinking, well, here's just another dickhead who's, doctor-focused, doctor-centric, thinking doctors should rule the world. It's not worked up till now. Why should it work in the future? Doctors aren't trained to rule the world. Surely we should be moving away from that.
Yep. The criticism is always of medical chauvinism when you argue we need a doctor-first health planning cycle. But health systems, and in fact I think, remember that the general practitioners of the day are the apothecaries of the 19th century. And I see in the future the nurse practitioner occupying an incredibly important, if not majority role in primary care.
And of course, nurses don't want to be run by doctors. They say we're independent practitioners.
Well, I think they have different skill sets. And I mean, the whole hierarchical thing and the thing which is underpinned with the feminist debate is a very sad thing, because it's distracted the debate from where it needs to be. The debate's not around who runs what, but what skill sets people have. Most health systems have as the key role the differentiation of a patient's problem. That's where things either go well or badly. For example, a breathless person walks in to see you and me, and that breathless person is differentiated into asthma or pneumonia or heart failure or pulmonary embolism or hyperventilation syndrome or whatever. That differentiating role is the most demanding, challenging role in the health service. And if we get that role wrong, then everything goes wrong. If that role is properly resourced, then in fact we can end up with all sorts of outcome and cost efficiencies flowing on. To me, that is the role of the doctor. It's that differentiating role which justifies all that money.
Diagnosis, management, planning.
Absolutely. Now,
and training the right people to actually manage the condition from there on, which might be the doctor or it might be somebody else.
Likely somebody else. And now the point about this doctor first policy is until we have this debate and have it with maturity about just what doctors do in the future, until we have that debate and have a very clear idea of the social contract we have in terms of the scope of the doctor's practice. If doctors in 2020 are going to be doing cataract operations and varicose veins, we're going to need a hell of a lot of them and not much of anything else. If, on the other hand, we're to say no society can tolerate using a 747 to deliver the milk, I mean, if they say no, if you're going to train 747s, use them to fly between continents. If that's the case, then our aligned health workforce is going to have to be very large and very heavily differentiated. So my doctor first planning cycle is not born of medical chauvinism, it's born of pragmatism. Because until we know what that expensive part of the health system is going to do, then just what is the scope and what is the number and what is the range? So it lends itself to the complaint of medical chauvinism, but the outcome's quite the opposite.
And just finally, you talked several times about incentives.
Yes.
Describe what those incentives look like. Is it just more money? Is it, as
No.
Andrew and Bevan would say, stuff their mouths with gold?
Yeah, it is fair to say at the moment there's an economic malalignment driver. That's true.
That you can earn $1 million a year as a knee surgeon, but
Precisely.
not as a cognitive general physician.
Precisely right. So there are economic drivers. No, I think the major issue there is status, actually. And when we look at, I'm trying to work at why so few of our graduates want to do primary care, when in fact to me it's the most challenging. I'm not a general practitioner, but as a physician I look at my general practice colleagues in awe, given the nature of their practice and the demands on them. So why is it that our students are disinterested? The answer is status. Now remuneration is one of the contributors to status, but status is more than just money. Status is the standing that you have amongst your professional colleagues, the standing you have amongst your community. It is to do with the range and scope of the things you do. It's to do with what you think the value you add into the health system. So for me, remuneration is a step towards the realignment of utility and need, but it needs to come with a deliberate perspective of status. And it's not something we actually even debate in medicine because we're frightened of appearing slightly arrogant.
But you can't buy it, you've got to earn it, haven't you?
No, I think a status comes from the perspective of a professional group which has clear career progression, clear training, appropriate levels of remuneration, and a sense that what's being done within that disciplinary group makes a difference. And I think what we've seen in the last 25, 30 years is an undermining and undervaluing of the generalists, and particularly the general practitioners. Added to that, there's the economic incentive to get into being an expert in the left anterior descending coronary artery.
But when the decision comes as whether you're going to practice in Wellington or in rural New Zealand, it's often the partner saying, well, where are our children going to go to school, as much as the status, and what can you do about that?
It's a very good question. Maldistributions do exist in demographic terms as well as cultural, ethnic and disciplinary terms. And interestingly, schooling has probably as big an effect on where doctors end up working as they do elsewhere. I think the solution may come, Norman, from this next generation of graduates who I do not believe will be singular in their discipline or in their work location as we were. We entered a system which was siloed both in terms of our discipline and where we ended up practicing. I suspect this generation, in fact I'm sure this generation, what they tell me, will probably change career 3 or 4 times. And what we have to try and make for them is that a period of rural practice, even a prolonged period of rural practice.
So they might be 5 or 6 years and then they move on.
It at least provides an effective health workforce in areas of need, bearing in mind that New Zealand does not have anything like the rural health issues that Australia does. Rurality in Australia is a very major issue, but in fact that may be counterproductive. By that I mean rurality in New Zealand doesn't lend itself to the wonderful breadth of practice that rurality on Australia does, and so a provincial New Zealand doctor may have a lot of the downside of a rural Australian doctor with the upside, that is
procedural work and things like that.
Absolutely, and also a standing in the community where they are viewed by that community as being someone very, very special.
Professor Des Gorman, thank you for joining us.
You're welcome, Norman.